So when we talk about visual acuity assessment, it is very important for we, the optometrist or any eye care professional, to know what is visual acuity. So it is a spatial resolving capacity of the visual system. This is the definition that was given by Benjamin in 2006. So you can see this farm of sunflower, one that shows how it will look to a person with normal vision, and the other one that shows how will it look to a person with refractive error. So you can make out the differences between the two images. One has sharp edges, sharp demarcation line. It is well demarcated. One petal from the other petal can be seen in detail. But in case of the other image, it looks blurry. So the fine details are not there. So what does it tell? What does this visual acuity tell? This letter, the 6 by 60, these measurement, or 20 by 20, what does it tell you? So the visual acuity, these values that we get in visual acuity, tells you about the refractive status of the eye. How is the cornea? How is the lens? How is the aqueous humor? How is the vitreous humor? These are the refractive components of the eye. And it also tells you about how well the retina is it healthy or is it unhealthy? Is the fovea damaged? Or what is the condition of retina? So visual acuity is just not the value, but it also tells you what is behind it. And not only this, whatever is formed on retina, whatever image is formed on a retina, that is actually perceived by the brain. So even if the eye is completely healthy, the neural integrity is not well, then the visual acuity will not be good. So visual acuity helps us understand about all these things. So when we talk about the ability to see, there are certain tests. I would like to briefly mention about these tests, and then we will move towards the visual acuity test. So when we talk about the ability to see, we have minimum detectable resolution, that is able to just detect whether something is present or absent. For example, this image with a white dot on the black background, it is just about the detection. Can you see the white dot over this black background? Yes or no? So that is detectable resolution. The second is minimum resolvable. So this is something that you see in the visual acuity charts, with the vision charts in the clinic, the tumbling E chart, the landlord C chart, the optotype chart. So these comes under minimum resolvable. Resolvable. So it is what are you able to resolute? What is the resolution? So what are you seeing? Are you seeing C? Are you seeing E? What are you seeing? Then comes the minimum separable. What is the ability? I mean, how well is the ability that you can perceive the separation between the two objects? So one example is vernier acuity, and you can see the example here. There are two vertical lines. The separation of these lines are more than these ones. So that comes under minimum separable. So this also helps you to understand the ability of the patient to see anything. And then the stereo acuity that tells you about the depth perception. So in this particular presentation, we will be focusing on minimum resolvable. Moving ahead, we should first understand the principle. So how does this work? These charts are just simply design of what? So here, in this diagram, we have B, A, and C. These are the three cone cells that is in the fovea. So for example, these blue objects are the two different objects. And now the rays from these two different objects are falling, are just intersecting at the nodal point of the eye. This is the nodal point of the eye and is falling on one single cone cell of the fovea. So in this case, if the rays from two objects falls on one single cone cell, that two objects will be perceived as one object. The brain will not perceive it as two different objects. Now, if you move these two objects further away, which is now at this orange position, And if the rays coming from these two objects falls on two adjacent cone cells of the fovea, then also it was seen that the object is not perceived as two different objects. So it is perceived as one object only. Means the fine details of the objects are not well perceived. Now it was noted when the object is kept at this A point where it is mentioned as A and not as at B. So this separation subtends an angle of 1 minute of arc at the nodal point of the eye when the light coming from these two object intersects at the nodal point, then it subtends an angle of 1 minute of arc. And in this case, what is happening? These rays are falling on the alternate cones. So in this case, the image of two objects will be perceived as two different objects. So this is what the whole chart, the whole visual acuity chart is based on. So when we talk about an optotype that we see in our vision chart, then this E is one of the example here. So this one leg of the E subtends 1 minute of arc on the at the node on the fovea, and this another leg subtends another 1 minute of arc, and this space between the two legs also subtends 1 minute of arc. So that is why we are able to see this E as E and not just as a spot. So moving towards the notations that we commonly use in visual acuity. So there are several notations we have when we measure the visual acuity. Here we will talk about the most common ones. The most common one that we use is the Snellen fraction. Then we have feet. Then we have decimal notation. Then we have logarithmic of minimum angle of resolution, that is known as logmar. So let us see what is a Snellen fraction. So here is a small chart that is given here. You can see it has a value of 6 by 60, 6 by 36, 6 by 36, 6 by 24, 6 by 18, like this. What does it mean? What is this 6? What is this 6 by, what is this 60? So something that is at the top, that is a numerator, that is a fraction, is the numerator, and something that is at the bottom is the denominator. So what is the numerator here? 6, 6, 6. Everywhere it is 6. It is the distance at which the test is done. Okay, so that is the test distance, is the numerator here. And what is the denominator? The 60, 36. So this is the distance. This denotes the 60, this 36, this 24. These denominator denotes the distance at which letter substance 5 minutes of arc on the fovea. So this is what is the Snellen fraction about. So in this chart, for let us assume the patient has read the 6 by 6 line completely, and it is an unaided visual acuity, that is without any glasses or any refractive correction. So the patient has read the 6 by 6 line with the right eye. So how we will record this vision? We record this as OD 6 by 6. Similarly, for the left eye, the patient has read only the 6 by 6 line completely. So that is why we have written 6 by 9 here. Now, in certain cases, what we observe that the patient cannot read the whole line. Okay, maybe can read only 6 by 6, two letters in 6 by 6, and not the rest of the letters. So in that case, there are different ways to express the visual acuity or to record the visual acuity. We can mention it as 6 by 9 plus 2. That means that the patient has completely read the 6 by 9 line and the two letters from the next line, that is 6 by 6 line. Or you can also write it as 6 by 6 minus 5, 1, 2, 3, 4, 5. The 5 letters were not read, but the 2 letters were read. So 6 by 6 minus 5. Or simply you can also mention 6 by 6 parts. There is no any rule like you have to do it like plus 2 or minus 5 or this parts. So it depends completely upon upon the place where you're working, how they follow. Do they prefer writing in 6 by 9 plus 2, like the line that was read completely, along with the letters that was read in the next line that was not completely read? Or do we just subtract the number of letters that has not been read, or just mention parts? Okay, so one thing I have always noted, we always use this word OD, and everyone knows that OD means right eye. But when in Viva, this question comes up from the teachers. When even I was a student, I have always missed this. What is OD? What is the full form of OD? So that is why I have kept it here. It is oculus dexter. OS is oculus sinister, that is the left eye, and OU is oculi because it is plural, both the eyes. UTQ. No, so it's not only about lectures. No, let us have some interaction. So I have a question for you. Just say if a patient has read only 3 letters of 6 by 9 line with his right eye, what will be the visual acuity?
6-9 parts, ma'am.
Okay, very good. That is the right answer. So there are other answers also it could be. So it could be like 6 9 minus 3. So 6 9 parts is the right answer. Or 6 9 minus 3 can also be the right answer. Now coming to the next notation, that is the feet notation. So 20 feet is equal to 6 meters, and this conversion is very simple. We all know that 1 feet is 0 0.3 meter. So if 1 feet is equal to 0.3 meter, then how do we convert the 6 by 6 uh, thing, this 20 by something into meters? So you just have to multiply the denominator of this feet notation by 0.3. So it will give you the answer in meters. Now, when you want to convert the meter into feet notations, then you have to do what? You just put the numerator of 20, that is the feet, 20 feet, and in denominator, you divide the denominator by 0.3. So that will give you the answer in feet. That is the easiest way. That is the way you convert from feet to meter and from meter to feet. So let us see some examples. So 20 by 20 line. So if you use the formula 20 by 20. So here it is 20. So 20 into 0.3 is 6. So that is why 20 by 20 is 6 by 6. 20 by 30. So 30 into 0.3 is 9. So we just put 6 here and then 30 into 0.3, that is equal to 9. So 20 by 30 in meters will be 6 by 9. Similarly, for 6 by 6, it will be 20 by 20. So what are we doing here? We're just putting the numerator 20 here and the denominator 6. We need to divide it by 0.3. So if we divide 6 by 0.3, we get 20. That is why it is 20 by 20. Then the next is 6 by 9. So 6 by 9. So you just put numerator 20 here and then you divide this 9 by 0.3. You will get 30. So that is how the conversion is done. And this is about plus 2, minus 5. So depending upon the number of letters read extra or number of letters missed, you just place the same thing on 20, on feet notations as well. So there is nothing regarding this because it just donate the number of letters. So that will remain the same. You can also write 20 parts. Moving ahead, okay, so another question. So unaided OD vision is 2040. Can anyone tell me how much will it be in meters? Yup, right, 6 by 12. That is the right answer. 6 by 12 is the right answer. So we have just multiplied 40 with 0.3 and that equals to 12. So 6 by 12 is the answer. Now coming to the logmar visual acuity. So logmar visual acuity is one of the standard visual acuity measurement. When we talk about research purpose, then this is the most preferred one. Now, why is it most preferred one? Because in this, there are certain features of it. If we observe this, there are 5 letters in every line. Every line has 5 letters in it, whether it is 6 by 6 line or it is 6 by 60 line, doesn't matter. Every letter have the 5 letters and each letter has a value. The value is 0.02. So 0.02, 0.02, each letter has the value. So it comes or to be on a continuous scale. It is very easy to analyze the data from if you record visual acuity using logmar chart. So if ever you are planning to do research, then it is recommended that you use logmar chart. It is also used in low vision because each letter counts. So let us see how to record the visual acuity. So it is something that is not found very usually. So that is why sometimes we get confused about how to record the visual acuity. So what do we do? For example, let us take the example. If the person has read, I'll just make it a bit larger. So if the person has read this 0.9 line completely, what will be the visual acuity? So if you see here, these values are the logmar values. So you simply mentioned the I for which the visual acuity is 0.9 and that's all. But if the person has read only, for example, 3 letters of 0.9 line, okay, so what do we do? How many letters were not read? 2 letters were not read. So here is the formula. Same line value, that is 0.9 plus 0.02, that is the value of each letter, multiplied by the number of letters not read correctly. That is 2. So 0.02 multiplied by 2 is equal to 0.04 and same line value is 0.9. So the answer is 0.94. This is the visual acuity of that person. Now another way of taking the recording the visual acuity in the logmar, you can also take the value of the upper line. Here it is 1 logmar. You can take this value and subtract 0.02 multiplied by the numbers of letter read correctly. So numbers of letter read correctly is 0.3 letters. So 0.02 multiplied by 3 is 0.06. And upper line value is 1. So 1 minus 0.06, that is equal to 0. Yeah, 0.94. So that is the visual acuity. So in both the cases, the visual acuity is the same. You can use either of the formula.
Pinaz, a good thing. Let me become a patient here right now because we really find logmar equity maths being a little difficult. I think the plus part or minus. Let me assume to be a patient here with you and I would read the visual equity chart. Let me read that. HVZDS NCVKD CPSH and R. So in the third line, I've read 3 correct. So would you guide us in putting that in numbers?
Yes, ma'am, sure. So, ma'am has read 3 letters correct in this third line. The value of the third line is 0.8. So, in this same line, how many letters were not read correctly? They were 2 letters. So, again, the same line 0.8 plus 0.02 multiplied by the number of letters not read correctly is 2. So, 0.04. And then the same line value was 0.8. So, 0.8 plus 0.04 is equal to 0.84 is ma'am's visual acuity. Or the other formula, with the other formula also it will remain the same. You take the upper line value, that is 0.9, and subtract the numbers of letter read correctly, that is 0.06. So 9 minus 0.06 is 0.84. So in both these cases, we have the same visual acuity, that is 0.84.
Thank you so much.
So
and it is all of you to be very clear because logmar visual equities are the most accurate ones. And it's a very simple thing. Whatever you don't read, you add 0.2 per alphabet to the line that is not read. Make sure you learn this, and if it is any clarification, we can discuss it in the last again. Thank you, ma'am.
So No, there is one more thing that is very useful in Logmar. So Logmar acuity chart is the most preferred chart when it comes to the low vision assessment. Now, what happens in low vision cases? So not in much detail, I'll discuss about the low vision here, but I will brief you about it. So what happens if the person is not even able to read these largest letters of the chart? What can we do? What can we do if it is a loose chart? Then we can bring the chart. For example, if it is a 4-meter chart, then we can bring the chart to 2 meters and ask the person to read. If the chart is a LCD based chart, then we can ask the patient maybe to move towards and come at a distance of 2 meter away from the chart. So if it is a loose chart, we can bring the chart closer to the patient. And if it is a LCD chart, and the low vision person can be asked to move a bit ahead, or you can change the calibration of the LCD chart and reduce the distance from 4 meter to 2 meter. So let us see how do we record this. So when you're reducing the distance to half from 4 meter to 2 meter, then what do? We record the visual acuity with the eye covering the one eye that is not tested, and we record it and we add 0.3 to the recorded visual acuity for every half distance reduced. So for example, after reducing the distance to 2 meters, the patient reads this first line completely and is not able to read anything on the second line. And the visual acuity is 1 here. So you add 0.3 to this one, it becomes 1.3. So you can write unaided OD visual acuity 1.3 logmar. So, and even if at 2 meter distance, if the patient is not able to read a single letter from the chart, from the even the biggest one, then you can reduce the distance further to 1 meter. When you reduce the distance further to 1 meter, you again add 0.3 to the recorded visual acuity. So you, after coming to 1 meter, you simply ask the patient how much the patient can read. For example, the patient's visual acuity is 0.84. Then you just add 0.6 to 0.84. So that will be 1.4, 1.44. So this is an example with the logMAR visual acuity chart where the patient reads 3 letters correctly on 0.3 lines. Here is the 0.3 line. 3 letters are read correctly. So in order to take the visual acuity of that patient, what we have done, so upper line value minus 0.03 into letters read correctly. So it gives you 0.34, and then 0.3. This is another way where you where you add the unread letters from where you add the unread letters to the same line. So that also gives you 0.34. So another example where all the 5 letters were read by the patient. So the visual acuity is 0.3. All the 5 letters were read on the 0.3 lines. So after this, I have some questions. So these are the letters read by the patient with the right eye, or VK. These were the letters read correctly in the 0.9 line. So what will be the visual acuity of that patient with the right eye at 4 meters, 2 meters, and 1 meters? You can put your answer in the chat box. So what was the visual acuity at 4 meters, 2 meters, and at 1 meter? Yep, many of you have answered correctly, completely, and many of you have answered uh, correctly, I mean, to the first part. So let us see the answer now. So for 4 meter, the visual acuity will be 0.96 logmar. For 2 meter, it will be 1.26 logmar. And for 1 meter, it will be 1.6 logmar. So moving ahead, so another notation is the decimal notation that is not frequently used. Maybe at some places you might see this. So this is a very simple notation. You just reduce the Snellen fraction or the feet fraction to the decimal quantity. That's all. So if it is 20 by 20, so what will you get in decimal? It is 1.0. If it is 6 by 6, you get 1.0. If it is 20 by 200 or 6 by 60, you get 0.1. That is simple division. You just have to get the value in decimal and nothing else. So this notation is generally used in European countries. I don't know if it is used in nowadays also or not, because this is something I have got from the textbook that it is used in European countries. With my personal experience, I have never seen anyone using this notation in the clinic. So that one thing, that one drawback in this decimal notation is, so this decimal does not specify the distance at which the test was conducted. So these were the different notations we have covered so far. We have just had a glance at meter, feet, decimal, and log mark. Let us see what is ahead. So this is something a must-have in a clinic, a LCD vision testing device. Now, why is it a must-have, I'm saying? Because in this single LCD vision testing device, you have multiple options. You have Snellen chart, you have logmark chart, you have a single row chart in which all the letters are written in single row. You have a single column chart in which all the letters are written in a single column. So I have kept a video here to just take you all through the options of this LCD vision chart and why is it a must-have chart. So you have different charts and all the charts are there at one place, in just one place. So you don't need to have different charts in your clinic. You just need to have this LCD vision testing device and you can have all the charts at one place. So you can see we have the Slennon chart, then we have logmark chart, then charts in different languages, single row, single column, and single letter. We also have ETDRS chart, and there are lots of other stuffs also here. Then you have contrast sensitivity testing chart. So all these things are in one thing. You don't need to have a single letter chart separately for an amblyopia patient. So you can just use it. Not only this, it has also certain other options like distance calibration option. So if you look into this distance calibration option, so for example, you have a clinic that is giving you a distance of 6 meters right now. You can measure the visual acuity at 6 meters. Now, what happens that you are trying to, you have a planning that you divide the clinic into two parts, and maybe in another part you are thinking of using a vision therapy setup. So you are dividing your clinic into 3 meters. So you don't need to change the charts and everything you have in your clinic. You just can calibrate it for the distance that you are having. So let us see the calibration part here. So if you look at this calibration part, so from 3 meters, you can change it to 5 meters, 6 meter, or you can even reduce it. So I'll show the reduction also here in the video. So here you can reduce it to 1 meter also. Let us see how the chart looks when you have reduced it to 1 meter. So I'll just, in the video, we'll go back to the main menu and I open up any chart here. Yeah. So you can see this chart is now calibrated for 1 meter distance. This is the Snellen chart. So even if you have only 1 meter left for your clinical setup, you can just calibrate the chart for 1 meter. Or you can calibrate it to again 3 meters. So depending upon the distance that you have, the space you have in your setup, you can calibrate it. So let us move ahead. So what are the things, for example, you also tried taking vision at different distances, like at 3 meter, 2 meter, 1 meter, nothing is working. The patient is not able to perceive a single letter. So what do you do then? You can start with, there are certain other notations that is usually you can see in visual acuity testing. The one is the finger counting. So you start asking, it is very easy to perceive like how many fingers can you see than to perceive details of the optotype. So you just ask the patient like how many fingers you can see. So finger counting is the farthest distance at which the patient can count the finger. So you start at 3 meter. If the patient is not able to perceive, you come at 2 meter, you come at 1 meter. So you record it accordingly. For example, the patient perceives it at 1 meter. You test it, moving it little bit ahead, little bit back, at what distance the patient is able to read. So if it is 1 meter, you write finger counting at 1 meter and the eye for which you are taking this. Make sure you occlude the eye that is not under the test. Similarly, for the left eye, even the finger counting at 1 meter is not working, then you again reduce the distance to 50 centimeter. And there also, if it is not working, then you reduce the distance further to 25 centimeter and maybe close to face. So then you can mention, if the person is able to identify the number of fingers close to face, then you can mention it as FCCF, that is finger counting close to face. So this is the time when you have to remove the trial frame from the patient and you have to check it without the trial frame. So you need to tell the patient to occlude the eyes with their palm and then tell you whether they can see the fingers or not. If yes, how many fingers can they see? Even if the finger counting is not moving, it means the details of the fingers are not perceived by the patient. You can start with just simple movements, that is the hand movement. So what happens in the hand movement? So it is very easy to perceive. If you just put a 20 diopter lens in front of you and do finger counting or you hand movement, you will understand like being like how easy it is to perceive a hand movement or a finger counting. So when we talk about the hand movement, you start at 1 meter distance, reduce the distance to 50 centimeter. If the person is not able to perceive it at 1 meter, and if even if the person is not able to perceive it at 50 centimeter, you reduce it further. So then you mention it as hand movement at whatever centimeter, or hand movement 50 centimeter, hand movement 20 centimeter, or it is just the hand movement near to the face. So you just record it simply hand movement positive. Even if and if the person is not, if the patient is not responding to even the hand movements, then the next step is to see the light perception. So what do you see in light perception? You just put a torchlight in front of the patient's eye and you just wave the torch. Patient's eye ke samne torch rakh ke you just wave it and ask whether can you see the light or not. If the person says yes, they can see the light, then the test does not stop there. You have to check for the projection of rays also. Like if the person is able to identify the light is coming from right, left, up, down, what? Which direction? The direction from which the light is coming, or is not able to perceive the direction from which the light is coming. So that detail is also very important. So it is PL positive, and if the person is not able to perceive the direction, is not able to detail you about the direction from which the light is coming, it will be projection of rays negative. Similarly, if there is no perception of light also, so there is no perception of light and you record it as NPL. So you cover the test eye that is not being tested, and you project the light in different directions. You can see the image here. This is the image of our GDGU clinic, and these are my students. So they are projecting the light from upside, downside, then from this temporal side, and then similarly they'll do for the nasal side also. So if in all the four quadrants, the patient has perceived the light correctly, telling like, yes, it is coming from the right side, it is coming from the left side, it is coming from the up, it is coming from the down. That means the answers are correct. The projection of rays is well perceived by the patient. So you just write the tick. You just mark it like a tick in each of the quadrant that you have tested. So this is how we record this. This is important. So you have to make this quadrant and just put it tick. And here you write PL positive, PR positive. And this image gives you the detail of the projection of light. If in any quadrant there is no right projection, patient is not able to identify, you just cross it. The next important is the pinhole testing. So when do we do this pinhole testing? Do we do it on a patient with the movement who cannot perceive the letters? No. So we do it when the person has some visual acuity. So if we talk about the textbooks, it is said the person, if they have a minimum visual acuity of 6 by 60, then we should go for the pinhole. But when I talk about my clinical experience, then I have seen like high myopic cases where there is a visual acuity worse than 6 by 60, their vision also improves with the pinhole, with the pinhole. So what is happening with and without pinhole? What is happening? So here is an image where the light rays are coming from the object, they enter inside the eye. Because there is a refractive error, it will either focus in front of the retina or behind the retina. So the light that falls on the retina is all spread here and there. Okay, so that is why it is all blurry. Now, what does pinhole do? Pinhole will cut down all the light rays that are coming from here and there, and only the light rays coming straight and falling on the will be able to enter the pinhole, and it will fall exactly on the fovea. That is why the vision improves with the pinhole. So this is how the pinhole works. And if the vision improves with the pinhole, that means there is a refractive error, the loss of vision. The reason behind the loss of vision is a refractive error. And if sometimes in some cases, the vision even deteriorates after using a pinhole, that indicates that there is some pathology involved. Maybe, for example, you can take a macular degeneration, a case of macular degeneration. So when you use a pinhole, in that case, the vision will reduce further. Okay, so here are some images. Can you tell me what is it? Do you think it is the right thing, or is it wrong? So I'll just maximize a bit. Wrong. Okay. So what is happening here? The patient has some space between the nose and this occluder that the patient is keeping in front of the eye. And so there is a scope that the patient can peep from this side. That is why this is wrong. So let us move to the next slide. What do you think? This is wrong or right? So if it is right, why is it right? Or if it is wrong, why is it wrong? Wrong, others should be closed. Wrong, because gap in between the fingers. Very good. So yes, in between the fingers, there are gaps. There are gaps, and though we are taking the visual acuity for the patient's left eye, the person's right eye is also actively seeing the vision chart. So whatever recording is will be there for the visual acuity, that will be wrong. So let us see what next slide has. Okay, so another thing, again, this is also wrong. Now I can understand that all of you are very very active in picking the mistakes here. So yes, again, this is wrong. The patient is able to peep from here. So we need to make sure that the patient covers the eye that is not being tested very carefully, and that too with the palm. If they are using their hand, they should not press their hand and should completely cover the eye that is not being tested. What is the problem here in this picture? What do you feel? So we are doing a visual acuity testing here, and the patient is covering the eyes. So what do you think is a problem in this image? Very good. Oh my gosh. That is such a nice response. The room illumination is low. That is true. So while taking visual acuity, we need to make sure that we have proper room illumination. So if it is not a perfect room illumination, then the recorded visual acuity may go wrong. Let us see what is in the next slide. Okay. So again, do you find there is any mistake? Very good. The head posture, it is tilted. So it is like the patient can squint the eyes, is squinting the eyes, and it is tilted. So again, visual acuity may come as wrong. And what's the problem here? Glare, yeah, glare is also there. Light falls on the chart, reflections, the chart is not well illuminated. Yes, very good. So yes, both the things are there. There is a glare also, and the illumination is also not good. So we need to have a good illumination, and apart from that, we need to make sure that there is no glare problem. So there should not be reflection on the chart. If there is a reflection, the patient may suffer from glare, may not be able to see clearly, even a normal person. So even us, we can also not see that, the letters clearly. So that was all about the distance visual acuity notations. Now let us talk about the near visual acuity notations. So here we have N notation and reduced Snellen notation. That is the most commonly used one. We have others also that like M notation that we use in low vision for low vision purposes. So let us go through this N notation and reduced Snellen notation. It is very easy. You all must have recorded it. So this is a simple English reading chart, and these smaller letters are N6. So we start with something at the bottom, larger ones, age of 70, that's written here. So it starts with N36, N24 to N6. So if the person is able to read this N6 line, what is it? How do we record it? So we recorded, for example, the distance at which the patient read these lines was 30 to 40 centimeter. So you recorded as OD, right eye, N6 at 30 to 40 centimeter with near vision English reading chart. It is always preferred to describe about the distance, the range of distance. Don't mention a single distance. So you should always check the visual acuity within this 10 centimeter plus minus 5 centimeter distance. If you're keeping at 35 centimeter, you move it at 40 centimeter and check. You move it at 30 centimeter and check. So it should be like 30 to 40 centimeter. And we mention it with which chart you have taken this vision. So you have taken this vision with English reading chart or Hindi reading chart, whatever chart we have used. Similarly, for the left eye, it is 32 centimeter, it is N6 at 30 to 40 centimeter with near vision English reading chart. Moving ahead, we have reduced Snellen. So why is it known as reduced Snellen? Because these are the Snellen charts and has been reduced here. This is the reduced version. So that is why. So what is it? 6 by 6. If the patient reads the last 6 by 6 line, you can write it as 6 by 6 at 30 to 40 centimeter with a reduced Snellen near vision chart. You can also prefer to add more details like landlord C chart, reduced Snellen C chart, or reduced Snellen E chart, reduced Snellen dot chart, something like this. These details can also be added. So what is it, right or wrong? If it is wrong, what is the mistake here? So what is the problem here? When we are testing this near visual acuity, we should give this near chart in the hands of the patient. That is the best practice. Okay, so when you can hold it slightly, but you keep it in the hand of patient, so that patient will bring it, and you ask the patient to keep it at their usual distance and then read it. So this chart is too far and it is in the hand of the examiner. So that is why it is wrong here. So if the chart was in the patient's hand, maybe the examiner can slightly hold it to make sure that the patient does not make it too far just to make it readable, or make it too close to make it readable. So it should be at the optimal 30 to 40 centimeter. We also get to know about at what distance, when we are giving this near chart in the hands of the patient, we also get to know at what distance the patient is able to read it clearly. For example, if I give a hand in a presbyop's hand, chart in the presbyop's hand, the presbyope, in order to read the chart N6 line clearly or N8 line clearly, will move the chart further away from him or her. So by this, you understand right now at what distance you get an idea like, yes, the person is presbyope. If the person is myope, very high myope, then we'll bring the chart very close to the eye. So just give the freedom to the patient to move the chart, and you also record the visual acuity at the distance at which you want to record, like 30 to 40 centimeter. And there are lots of things in this near visual acuity. You need to ask the patient there about their usual distance. So if the person works very closely, or if the person works on the laptop, so their demands will be different. So we need to check vision based on their demands as well. So what do you think? This is right or wrong? No, well, yeah, this is right. Actually, everything in my slide is not wrong. So yeah, this is the right one. Thanks for yeah. No, people are responding right. Yes. So maybe because the image quality is not good to some people, it is appearing that the illumination is not good, but the illumination was good, and this is ideal. Ideal picture where the patient is holding the chart in her hand and is reading it. So this is again like it is she's trying to read at some far distance and then at near distance. So I'm giving the freedom to the patient so that I can also observe. And then I'll record my visual acuity at 30 to 40 centimeter. What was the near visual acuity? Okay, so now room setup and steps. So this is very simple. It's just a brief about everything. Like you have to prepare the testing room. When we talk about the preparation, we need to make sure about the proper illumination and the position of the vision chart. Make sure if it is a 3 meter distance between the patient and the chart should be of 3 meter. So these things should have been very, these things are very important and has to be taken care. The next is the position the patient. So let the patient sit comfortably. The head should be straight, eyes towards the chart, and then explain the procedure, what the person has to do. Okay, explain them how to cover their eyes, or what you will be using the trial frame, occluding the eyes, or when you're using the pinhole, you need to explain the procedure completely. Then you take the vision without the glasses, like unaided. So this is a proper occlusion with the palm. The fingers are not involved in the occlusion. Only the palm is involved, and then the person is reading from the left eye. So you cover the left eye, test the right eye, cover the right eye, test the left eye. Do not press the eyelids. Ask the patient to read the lines. We start from reasonably larger lines if we know that if we can make out that the patient can read uh, to 6 by 6. That is your assumption. So you start with the larger lines. If the patient is reading very efficiently, you just you can move to the smaller letters as well. You can maybe leave one line in between also if the patient is very efficiently reading that. So if the patient is having a refractive error and is finding it troublesome to read the letters, you make sure that you give time to the patient and let the patient take time and read each letter. Okay, and you also need to reinforce the patient by telling them less good you have read it the next letter. So you have to keep them uh, pushing to try further, to read further, and that is also very important. And then you record the visual acuity immediately. Okay, so you do not think that right eye it was this. No, I will do the left eye test and then I will record it. No. So many times you get confused and then you will be guessing what was the visual acuity. So each letter counts. So always remember. So whenever you have recorded the visual acuity, we have taken the visual acuity, you record it immediately. And then you repeat the similar things, similar steps for the near visual acuity also. So these are the some common errors that we always make, like not prompting them to try further. You need to give time. Every patient may not need time, but when it is required, you need to give them. So you need to prompt them to try further. कोशिश कीजिए पढ़ने का. Then permitting the patient to look around the occluder or their fingers, so through their fingers. So you need to make sure that they're not looking through their fingers. or using a dirty chart, maybe a near vision chart. It comes in every hand, so it becomes dirty. Particularly, I have seen if it is a region where people speak Hindi a lot, then that page that has that Hindi reading text, that page will be very dirty. So you make sure that the chart is not dirty. The problem is also the illumination. You make sure that the illumination is proper. The working distance should not be incorrect. It should, if you're not recording the results immediately, you may later forget it and keep guessing and just write something. That is not useful. If you have put the efforts in recording the visual acuity, you have given time for that, you need to record it immediately, because that matters a lot. So that was all about this. I would like to acknowledge my colleague, Ms. Kritika Gautam, and my students uh, for images showcasing the practical setup that was used in this presentation. So these are the sources from where I have got these contents.
The first step towards achieving your dreams is having the right coach. Get the best education with Learn Beyond Vision and make your optometry dreams come true. Download the app now.